You need to know why the doctor gave you your MG diagnosis. It's based on what? You need to hopefully know the onset age of your MG and the duration of the symptoms. You need to know the specific symptoms of your MG. You need to know whether you are ocular or generalized. Most people know about this. You need to know which antibody is involved, and we will talk about why that's the case. You need to know your thymus gland status. You need to know the treatment response, especially whether you belong to the refractory or non-refractory status. You need to really know every medication you have tried for the MG and the outcome, whether it's working, it's causing side effects, or whether it's not working. You really need to know every medication you felt that has worsened your MG, not because it has worsened somebody else's MG. You need to know the factors that may make your MG worse, then you have to try to avoid those. And you need to know your major coexisting health conditions. That include autoimmune conditions or conditions with other organs that may limit your choice of medications. Finally, you need to know the physician who treated your MG a little bit, and you need to know about your family doctor as well. That's a lot, right? All right, so how is myasthenia gravis diagnosed? In general, it needs a careful neurological or eye exam. And this exam is looking for MG-specific symptoms. Most patients, no matter what symptoms you have, you end up with an MRI of the brain. Most patients go to the ER, the very first thing to do, they think about a stroke. In suspected patient, you will need a blood test for antibodies. That's everybody. There's nobody with MG diagnosis without ever being checked for antibodies. Okay. Well, I take it back, unless you have congenital myasthenic syndrome and their family members. Okay. And you need a chest CT to evaluate thymus gland. That is in general everybody, no matter whether you are ocular or whether you have general myasthenia gravis. You need a chest CT at least one time. Okay. If you have worsening symptoms, you can argue you may need a CT again, but in most cases, you need a CT chest one time. Tensilon test is mostly unnecessary. To be honest with you, we cannot even do it at Cleveland Clinic. Okay. It took 2 weeks for my pharmacist to find a Tensilon for me. And it took another several meetings for they finally say that you cannot do Tensilon because you are not ACLS certified physician. You cannot do you only know how to do CPRs. You don't know do anything after that. Repetitive nerve stimulation is necessary in the minority. What do you mean by minority? It's some people may have, borderline antibody test. They may not have specific MG symptoms. Or you came to the hospital urgently. The antibody take about 2 weeks or 10 days to come in. The doctors need a result as soon as possible. The single fiber EMG test is mostly unnecessary if you have significant symptoms. Okay. Well, the diagnosis of MG is supported by treatment response in patients with characteristic symptoms. That is pretty much everybody. Okay, the diagnosis rely on a combination of characteristic or specific symptoms and signs, test results, and the positive treatment response. You need to know which one of these to support your MG diagnosis, or all of them. If you are unsure about the diagnosis, you can seek a second opinion, especially opinion from a neuromuscular specialist who know how to deal with MG. All right, why do you need to know onset, age, and duration symptoms? This is a general trend. This does not apply to everybody in this room, okay? The general trend is MG symptoms and the disease severity tend to be the worst and tend to be the worst within the first 3 years and to fluctuate more frequently the first 3 years. And I always said that this is like the marriage between me and my wife, right? After a few years, things get better. After the first 3 years, the course of disease usually gradual improvement of or steady state with fluctuation exceptions seen in the minority people. Again, does not apply to, when I talk about this, somebody with a hand, Dr. Lee, you're lying, I have been having this for 10 years. Well, you are the minority. The medical treatment after first years is generally less. Therefore, there is a chance of minimize medication usage. There was a question after the first session, talk about the medication. I've been on around for so many years, what to do. There is an upcoming study, it's called a reduced MG study. It's going to specifically address this question. Is you are on prednisone for so long, you are on Southside for so long, you are on Imuran for so long, how can we reduce the dosage, and then how far can we go? So that's coming. All right, what about the symptoms of myasthenia gravis? I'm going to go very quickly. Double vision, droopy eyelids, we typically see in the 90% of MG patients. Lack of facial expression or false smiling, most doctors don't notify this, even families don't notify this. Difficulty in chewing, everybody knows about this, jaw dropping, begin to select the food, choking more often with liquid. Shortness of breath, difficult to lie down, difficult holding arms up, difficult getting up from a sitting position, head drop or head lag. When you lie in the bed, your body go up, your head leg behind, or when you're standing up, your chin begin to touch the chest. Fatigue and leg energy. You need to be familiar with the symptoms so that you can easily recognize exacerbation. Typically, when your MG, coming back, it's mostly the same symptoms you had before. Okay? It's mostly, not every case, but mostly symptoms you had before. All right, there is this disease severity classification. This might be too much, but if you know the worst stage you are, it'd be great. If you tell people that I'm a MGFA 3A, your doctor will be very impressed. Okay. The zero, it was a remission. There was used to be no zero, but now everybody added zero to it. Ocular is MGFA 1. 2, 3, 4, 5, that is gradually increasing in severity, but 2A and 2B is basically different regions. 2B is not necessarily worse than 2A. All right, we always talking about the difference between ocular and generalized MG. I think everybody knows about this. In general, ocular, there are 3 symptoms. That is droopy eyelids, double vision, or difficulty in closing eyes. Difficulty in closing eyes is not easily detectable unless it is severe, but it's relatively easily detectable by physician's exam. Generalized, including what we call the bulbar muscles, that is problem affecting your speaking, swallow, and chewing. They are in the bulbar region of the brain called the brainstem. It's controlling that area. Axial muscles is neck, spine, and respiratory. And some people have abdominal symptoms, abdominal wall muscle weakness. Limb muscles, we're basically talking about arm and leg, usually proximal, but some people have hand weakness. More and more people being recognized have weakness in the hands. The pure ocular myasthenia gravis, 15% of all MG patients. Approximately 2/3 of the patients who had initially ocular symptoms will generalize, and that generalization usually occur within the first 2 to 3 years. Occur is in the 3 years is sort of a cut-off line. After 3 years, if you still remain ocular, the chance for you to generalize is exceedingly small. Well, there are many antibodies, and as you can see, everybody's familiar with AChR antibody. It's probably 80 to 85% of the patient. We begin to pick up more patients by testing antibodies. So this portion of the patient is actually increasing. Masking antibody in general is about 6% of the patient with myasthenia gravis. Mask antibody tend to be seen more in the northern part than the southern part. Everybody talking about IRP for antibody, not everybody here, it's, neuromuscular physicians. The chance of IRP4 antibody the incidence is relatively small, and most of people have a relatively mild phenotype. A lot of people have coexisting autoimmune conditions. We actually don't know whether the IRP4 antibody is indicated for myasthenia gravis or other autoimmune conditions sometime. Agri antibody, co-protecting antibody, they are exceedingly rare, and there are some unrecognized antibodies, and there are people who have more than one antibody, and that is usually exceedingly rare. Why do you need to know about your antibody status? Actually, I think this is the part that is often ignored, not only by people in this room, also by treating physicians. Okay. All right, the antibody status may influence the patient's confidence in diagnosing MG. The seronegative MG is almost always difficult and imprecise diagnosis. There tend to be error in not diagnosing this group of people and over-diagnosing this group of people. Okay. The antibody status may actually predict future course. We talk about this. Mask antibody positive MG tend to have a more refractory downgoing. The antibody level actually has some correlation with clinical progression. That's the part I want to talk about. It is once your diagnosis is made, your treating physicians usually don't recheck antibody anymore. In my personal experience, repeating your antibody in a year or two and looking at it, it actually helps. I actually have almost never seen a person, it's getting worse with an antibody going up. Okay. You cannot compare your antibody titer to somebody else's. Somebody else may not have antibody, but they have much more severe MG than you do. But your antibody level in yourself have some correlation with your disease severity. The antibody status may alter treatment options. Eculizumab, for example, has to be AChR antibody positive. Rituximab is particularly effective for masked antibody positive MG. Plasma exchange is more effective for masked MG than AChR MG. Cymectomy is generally effective for young patients with AChR antibody positive MG. Right now, we do not recommend a patient that has masked MG to have a cymectomy anymore. Your thymus gland, and it can be classified with normal thymus, mostly that is seronegative patient. Thymic hyperplasia, usually what it means is big thymus gland. Look at the one in the down and right bottom is a huge thymus gland. Usually it's younger patient with AChR positive MG. Thymus evolution is thymus atrophy. We typically see in elder patients, but in elderly after age of 25, there is a tendency of thymus to shrink. The thymoma is usually seen in middle age or older patients. I think most people are familiar with this trial. The trial is intermissional thymectomy trial. It takes many, many years to get this done. It's one of the best achievements we have ever had in the treatment for myasthenia gravis so far. And basically suggests that the thymectomy is very effective for a patient who have generalized MG, AChR positive, younger patient, usually younger than 65 years old. And the benefits is much more evident in lady, in patients who are younger than 40 years old. If you have ocular MG, if you are older than 65, does not mean you don't need to go through this thymectomy. The thymectomy still help you, and that might have to be individualized. Well, there are this term of refractory and non-refractory MG, and the definition of refractory varies based on clinical trials, but you can see that it's basically this group of patients. Usually it's less than, some people said less than 20% MG, but I think in most cases it's less than 10% of MG patient. The patient who failed corticosteroids and 2 other immunosuppressive agents of sufficient duration. Patients who clearly have intolerable side effects and you cannot use this medication, or patients in need of repeated IVIG, subcutaneous IG, or plasmapheresis. Usually this is a general MG, but although we do see people with persistent, very refractory ocular myasthenia gravis alone. A significant portion of masked MG patients will be refractory, and MG with thymoma is generally worse than MG without thymoma. You need to know our treatment options. This is a table list, hopefully it's all the medications we have been using for treating MG. And and hopefully you can have a table like this, whether you have used it or not, and you have a note whether you have efficacy or side effects. There are medications you have to avoid with, when you have MG. The list in some of the articles are very long. This is from actually the International MG Treatment Guideline, also another fantastic work done by the MGFA. It's basically listing. There are only a few medications that absolutely every MG patient should avoid. Okay, and that is intravenous magnesium, penicillamine, botulinum toxins. With that said, I have seen MG patient got Botox for wrinkles. Okay, I'm done. I have seen that. Use with caution. These are medications, and is some of the antibiotics, oral magnesium. Corticosteroid is listed as being used as a caution. Contrast agent, beta blockers, especially in the ICU, and statins, but those are relatively contraindications. The last one I sort of linked out is PD-1 inhibitors. It's actually, right now, is one of the most common cause of iatrogenic myasthenia gravis. I think there are probably 200, 300 cases nationwide so far. MG has a fluctuating course. It can be triggered by infection, hot weather, surgeries, childbirth, medications, reduction of treatment, and those are the things you need to pay attention to and try to avoid if possible. Again, usually these fluctuations occur within the first 3 years of the course. There are a few things to say about the MG crisis. There are lots of anxiety about this. I just want to clarify this. The myasthenia gravis crisis do not usually occur in isolation. Usually associated with other MG symptoms like speech problem, swallowing problem. Usually there is a cause. It cannot come from nowhere. It cannot come from an argument with your wife or husband. Generally that doesn't do it. Do not go away without treatment adjustment. Do not occur suddenly without a gradual evolution for a few days to weeks, especially if you are already on immunotherapy. Usually not manifesting episodic shortness of breath with exertion only. Usually not manifesting as sudden episode of shortness wake you up at night. Oh, I'm having a crisis. That does not occur. That's not a crisis. What about the exercise in MG? There are some things, there's actually studies done about this. I just want to go to the bottom of the slides, some recommendations. You can do regular exercises. It doesn't hurt. It does not hurt your muscle that much. You need to avoid prolonged induration type of exercises. You should only work out after adequate rest. And exercise during cooler time is probably preferable than hot weather. Coexisting conditions. There are two kinds. One is coexisting autoimmune conditions. That is autoimmune thyroiditis, thyroid problem, typically seen in 1 in every 4 patients we see with myasthenia gravis. But there are other diseases like rheumatoid arthritis, lupus, multiple sclerosis, irritable bowel syndromes. I have seen quite a few patients with lupus and rheumatoid arthritis. When they taper the medication, the MG show up. Typically, I go back to the medication that control their lupus, and that usually do the trick. Okay, the other is coexisting that may influence the choice of medications. Diabetes, of course, osteoporosis, of course, GI illnesses, liver, kidney dysfunction, whether you have a cancer or not, or whether you try to be pregnant or not. And this will help your physician pick up a drug that's appropriate for you. There was one final thing I want to say, that is, we do get a lot of people getting records, get people come see us for second or third opinion. What I hope when you to see a different new doctor, you should carry your records with you. Keep the record yourself. Don't expect our healthcare facility will deliver the records for you. You will be very frustrated. When you give records to your new doctor, you just need to see one thing. Doctor, After you see it, give it back to me. Thank you.
Okay, so knowledge is certainly empowerment, and I learned a lot, thank you. And so isn't a wee bit of feisty. And if you ask any of my friends, they might say a lot bit of feisty. But that's okay, it's a good thing, it's for us. So a little bit about my story. It all began in 2014. I was having a wonderful time at a cookout, and all of a sudden, I started talking like this, and I couldn't say my S's, and Disney World was coming in funny, and I talked like Elmer Fudd and Donald Duck. I mean, it was that kind of combination. And my friends panicked, of course. I, knowing full well the signs of a stroke, stood up, smiled, and did the precursor of, the baby shark. I did the Macarena. It's like, see, I can do this with my arms. I am not having a stroke. So while they scattered to get aspirin, a car to take me to the hospital, I kept thinking, oh my God, I've got to shower before I go anywhere. I got to clean the house. I'm having company over the weekend. I was not concerned initially. So I was taken to a small hospital in Maine, which, by the way, if you're ever in Maine, hot and cold running lobster rolls anytime you want them. So I was like, okay, I don't care. I just call down, get my lobster roll, and I was a happy camper. So despite all of the speech impediments, the coughing, the choking, they conducted numerous tests. The neurologist in that hospital, who has since been educated, I've sent him a lot of literature and talked with him, said, well, I don't know what it is, but here's stroke medication and here's some seizure medication. And it just totally blew me away. And I said, no, thank you. Just get me to Mass General. Went to Mass General, and it took a good 8 weeks before I was properly diagnosed. It was a simple blood test, and I was totally bewildered. That's the picture of a librarian that I like, rather than Marion the librarian or the pug with the, shh. So I look at it as super librarian does the research. And I went to, when I went to the doctor at Mass General, he, initially a very good diagnostician, said, I think you have myasthenia gravis, which I couldn't even spell, let alone understand. So I really had to do some research about what is myasthenia gravis. And I went on the internet, and I've got some warnings about that later on, podcasts, the MGFA, local groups, lots of homework and reaching out to people. I sort of reignited the activist of my college days and said, I really need to take charge of this. This is this weird, unknown disease, and I need to understand it better. I'm one of those kind of people that have to really understand something before I delve into it. Support group meetings and conferences, and finding the right neurologist. The first person, who was a very good diagnostician, I have to give him credit for that. I had the blood test, and he said, call back in 14 days. Now, that's 14 days of anxiety. I don't know what this is. And the more I read, the more confused I am. So, of course, being the kind, generous person that I am, I gave him 15 days and called back. And the response was, I told you 14 days. I don't have the answer. I'll call you when I have the answer. Well, as my mom would say, that totally jarred my preserves. I knew I depended on this guy for a very short period of time. And then what really kind of sealed it is once he had the diagnosis and called me, it was Halloween night, I will remember it well, and he said, well, yeah, confirmed, you have myasthenia gravis, and I'm going to prescribe 60 milligrams of prednisone for you. See you in 6 weeks. No, 6 months. No, don't think so. This is not the kind of relationship I needed. Maybe some people can deal with that. I could not. To me, this is a relationship for a very long time, and it's not going to be, here's the drugs, see you in 6 months. Needless to say, I found another neurologist who is dynamite. And that I can't say how important that relationship is. I know the person, she cares about me, she monitors the MG, she trusts that I know what the heck I'm talking about when I tell her about various symptoms, and that's just so important. So, look around, find somebody that's a fit for you, what your needs are, what your personality is. Just find the right person, because this is a real long-term relationship, almost like a marriage. These were the various drugs that I was on, had all kinds of reactions to them. I was hospitalized a couple of times, so it got pretty ugly at various points. I was declared refractory, and I used to call it recalcitrant. For some reason, that kept coming into my head. So after negotiations with the health insurance companies, and this I really have to give credit to a lot of the work that the MGFA does in getting that research data, because I had to give packets like this to the insurance companies. And the hospital did. They have an ombudsman that worked on my behalf. My neurologist worked on my behalf. I call the insurance company every day. They kind of got used to me after a while. I made a lot of friends. Wrote many letters, escalated. And in fact, the insurance company has changed its process as a result of some of the mistakes that they made as they were reviewing this case. So, hopefully this will benefit other people. I was kind, but I was also very emphatic. Rituximab has helped me. I've been allowed to taper the prednisone somewhat. Little less chubby cheeks, a little fewer bruises. And that is a good thing. And I'm almost normal, although I never was to begin with. The biggest part of what I do is educate any healthcare professional in your site. They're part of your team. And anesthesiologist, dentist, as Alexis mentioned this morning, GPs, gynecologists, ophthalmologists, pulmonologists, nurses, and most are very, very receptive. I did go to a pulmonologist lately, and I bring them all. We have a newsletter in New England, so I bring them the newsletter. I bring them the information that MGFA provides, because most of them don't have too many patients that have MG. So it's an education process. Most take it willingly, and I don't think they trash it because we have a discretion. I did have one pulmonologist lately who took it and said, yeah, it's in your file. Here, take it back. Bye-bye. See you later. Never going to go back. If somebody doesn't want to learn, they're not part of my team. The PCP is an advocate and ally. One of the things that Dr. Lee and I talked about is how important your PCP is, because the neurologists specialize in neurology. The PCP takes everything else. And I don't know about you all, but if I have something going on, it's like, oh, is that my MG or is that something else? You always wonder, oh, I've got a weakness here. Oops, my head hurts. Oops, this, So you always wonder. So it's good to have the PCP on board with you, and have him or her be part of the team. My PCP now, when I go and he has a student, he'll say, Denise, do you mind talking to my student? It's like, no, not at all. I don't mind talking anything, anytime, sure. And it's part of the education process. There are some times that I've been in the hospital where they've seen my medical alert bracelet and they've asked about myasthenia. And I've talked to them about it, and one of the times I was in, this woman said, oh my God, my friend who's upstairs in reception has MG. Can she talk to you? She just got diagnosed and she's scared to death. So you never know. We were at a restaurant last night, in fact. Good barbecue. Fox's Brothers, if anybody wants barbecue one night. And met a group of German scientists. They were cancer scientists from Germany. Started chatting, and we kind of compared notes, and we educated them about MG, and they educated us about some of the work that they were doing. The taxi driver that I had coming in said, "So what are you here for?" I told him. He said, "Oh, what's that?" And he was asking incredibly insightful questions, and he, of course, took advantage of the opportunity to learn. So you never know when you're going to meet someone that you can educate about what MG is. Insist on meeting anyone who will be part of your team. If you're going to have any kind of procedure, make sure you talk to the anesthesiologist. A lot of times, hospitals don't want to do that because these guys are busy, and I certainly understand that. I was scheduled for a colonoscopy and wanted to meet with the anesthesiologist, and they said, "Gee, they're too busy." And I said, "Oh, okay. We'll delay the procedure until they can take the time to talk with me." Whoa, they've got 5 minutes available on such and such a date. I mean, I really think that that's important. Somebody's notes don't necessarily translate to the next person. I want to talk to the person that I'm going to be working with, particularly with anesthesiology. And again, you can do it nicely, but be insistent. It's your body. Ask a lot of questions. I always carry either a notebook or my cell phone, and I keep notes of every meeting with every medical person that I run into. And I think you alluded to the same thing. Every specialist, every medication, dates, answers, and then you have documentation so that, again, you can help yourself at some point in time. And it really does provide more insight. Join the MG registry. Is Roger here? Can't see. Make sure you join the registry. It's a great way to increase the body of knowledge and help other people. It takes a little time. Embedded in this presentation are some hot tips, and thank you for this. Look at Costco and Sam's Club for meds. Sometimes you can get them for cheaper than your copay. Look around GoodRx and various online drug companies as well, particularly for some of the more common drugs. So look for good prices. Make sure that they're legit, though. There's some beware stuff. Beware of too much social media. I've been reading some of this stuff, and it scares the bejesus out of me. And I've had this for 5 years and studied a lot. Just be real careful at people you listen to with various kinds of drugs and therapies and herbs and spices and whatever. Talk with your doctor before you try any of this stuff. It might make things worse instead of better. Read professional journals, underline professional. Used to be Neurology now it's called Brain and Life. I don't think it's as good, but it does have some tips every now and then. Follow drug company research and clinical trials. If you don't have it already on your cell, put the MyMG app. It has some of the drugs that Dr. Lee referred to earlier that you need to be cautious of. I brought it to the dentist, and some of the drugs you should not take. So it's called MyMG, and it's an app, and it's free. It's worth having, truly. Read the chapter newsletters that you get and the MGFA newsletters. It's chock full of really good information. Get a medical alert bracelet. I love, Lauren's Hope. This is my teal. They also have the cuff bracelets, something that's attractive. I figured if I'm going to use this for the rest of my life, I want it to be cute. It's something that's semi-attractive. So Lauren's Hope is a really good source. Hot tip, and this is for those of us who are somewhat vain. Ice cubes. If you're going to have a picture taken, I did this for my passport. The lady at the post office just looked at me and went, "You're coming in here with an ice pack?" So I kind of put it on my eyes, and my eyes kind of opened up, and my passport looks much more attractive than it would have otherwise. So it's like, but I got this look like, oh, brother, what is this woman doing? If you're going to be at a wedding or need any kind of picture taken, because I noticed, and I'm sure a lot of you notice when you take the selfies or pictures with other people, that you look a little sometimes, when the ptosis is kicking in, it looks kind of funny. You look like you're closing your eyes. So, ice pack. Vanity tip of the day. Here's my sister could not believe that I actually put a bathing suit picture in there. And I'll tell you why. I wanted to give a sense of before and after MG. This first one is me before MG on one of Dean Kamen's inventions. So I was taking a Segway tour in the White Mountains. It was a Segway safari. The other one on the right side is after my diagnosis, and I love to boogie board, so another little tip here. Just before that, because my balance is not so good, I got hit by a big wave. I was rescued by a very cute lifeguard. So that's why the smile. The middle picture is I went on a windjammer a couple of years ago, too. And again, that was after the diagnosis. And I could help pull the sails, but I certainly couldn't pull the anchor. And the reason I show this is you can't tell a whole heck of a lot of difference between the two, the before and the after. And my point is, you've got to remind people sometimes, because everybody looks at you and says, you don't look sick, right? Most people don't realize it. You don't look sick. But people who know you, my friends, my family will look at my eyes and go, you need some rest, don't you? You're under a little stress here, aren't you? But for the most part, you can't tell the difference for some of us. And that makes it really difficult sometimes, because you kind of say, I've got to go to bed at 8 o'clock, I can't do it. I'm tired. You don't look sick. So, another hot tip, Family Medical Leave Act. If you have them, and most people should, do take advantage of that, because if you have continuing intermittent disease like myasthenia, it protects you in your employment. If you have appointments, sometimes they'll say, gee, how come you have so many appointments? You're out a lot. The FMLA will help you, and you're protected, and I would really look into that. Those of you who are still working, look into the FMLA, another hot tip of the day. Rest, I'm not the crazy hyperactive overachiever that my brain thinks I am. What I keep saying is that my brain writes checks that my body can't keep sometimes. It's just like, oh, I want to do this, I want to go there. I went to the aquarium, and I was like, okay, I can do this. I'll go through this area, that area. Denise, you just can't do any more than 2. You got to stop. And I could tell that my body was just getting exhausted. Get psychological support if you need it. Try yoga, try meditation. I think there's a session on meditation tomorrow, maybe. Whatever works for you, that I've found that to be quite helpful. Denial is a beautiful thing, and it's a beautiful river. But things change, and we really, really need to adapt to them. My last point is keep a sense of humor if you can. The first year I was diagnosed, I had ovarian cysts, one broken, it was just an ankle that time. I broke the leg in New Orleans. A couple of stints in the hospital. My mother had a stroke. That was the year from where. But, in retrospect, I look at it and I say, oh boy, I survived that sucker. Nothing can faze me now after that. And keeping a sense of humor was a good thing. It was incredible in the hospital that I had lots of doctors just lined up in a queue ready to see the myasthenia patient. So, it was great. I was somebody's entertainment. And it was an opportunity, again, an opportunity to educate. So I guess, yeah, the sense of humor is, I think, an important thing. We all have the trials and tribulations, but somehow you can kind of